Lovely. So yeah, I am Helen, and I was employed specifically to set up the new Perinatal Pelvic Health Service for Birmingham and Solihull, so bringing across 2 trusts. So Birmingham and Solihull, as I said, we have 2 trusts. That's over 4 sites. They're on different IT systems. They have their existing pelvic health teams who are brilliant and we're working closely with, but they wanted the new Perinatal Pelvic Health Service to sit slightly separate to them, just to, as we were getting up and running, to make sure we had protected time to actually get the service up and running. So our population...
Sorry, Helen.
Yes.
Not seeing it in presentation mode.
You're not. It is my side. So why not? Okay, let's stop sharing.
Pardon?
Let me... I'll share my screen instead of window and see if that works.
Perfect.
Yeah?
Yeah.
Okay.
Thank you.
Yes, so we have a lovely varied population across Birmingham and Solihull, but we have a lot of languages and ethnic diversity that we need to make sure our service is catering for. So those seldom heard voices that we actually get engaging in the service. We have 18,000 births approximately across the Birmingham and Solihull, and because the Perinatal Pelvic Health Service is open for that full perinatal period, so up to 1 year post-birth, that's up to 27,000 service users we're expecting through the service. The project plan for our Perinatal Pelvic Health Service was very clear that this was access to all women and birthing people, because we really want to have that massive preventative focus for the service. So that's an awful lot of service users we're expecting through a very small clinical team that we have specifically for the Perinatal Pelvic Health Service. So there's myself as the clinical lead. I have one band 7 physio. We have a specialist midwife, perineal trauma midwife, who we employed with the project funding, because one of the trusts had a well-established, excellent service and the other trust didn't. So we recruited into that role to get equity across the ICS. And then we also have one whole-time equivalent split over 2 individuals for physio assistants. So we've got such a tiny clinical team. And as I said, we will engage with the current pelvic health teams that we have across both trusts. But because they're already stretched, we wanted to make sure that we were keeping as much within this service and only referring on to them when absolutely needed. So that meant we had to go digital to achieve all that we needed to do, as well as the national specifications that we need to achieve for the service. So our pathway then, this will involve the perinatal pelvic health specific element as a one-stop shop. So there'll be a triage and treatment. We'll have point of care ultrasound, offer pessaries, and this will sit within that wider MDT. We also have that specialist midwife element, so perineal trauma and the OASI clinic. And they do the anorectal ultrasound scanning there. And again, that sits within this wider MDT. So the real aim is that we get this equitable service across the region, which isn't currently happening. Lots of good stuff going on, but it wasn't that equity of care. So we looked at various options, and the one that came out as hitting all the boxes was my pathway, because it achieves what we need to against the national standards, which is that single point of access, ability to self-refer as well as to have clinician referral, and it really simplifies being that one point of entry, which when we spoke with all the GPs, the health visitors, midwives, they all wanted one system, one route of entry, and this provided that. On top of that, we'll be able to offer so much more with it. I'll show you the pathway in a second, but we've got a resource full of library full of resources that we can share with everyone. We'll be able to get, we have proms on there, so we're going to have outcome measures for specific things, loads of data we're going to get from this as well, which is going to be invaluable. And then the national surveys that are being introduced for maternity care and also pelvic health specific that we're going to distribute through this system. And then from a patient's perspective, we're removing those gatekeepers, so they really can then choose when and how to engage with this service, which is just going to be invaluable for them. I'll move on to the risk and symptom questionnaire in a second, because this is how we will run this as a pathway. So at booking, antenatally, and then as soon as they've delivered postnatally, they're going to get an invite to engage with the service. And we've created loads of patient resources with Make It Creative to get that engagement. We've been delivering pelvic health training over the last year and a bit across the region, particularly to health visitors, midwives, but also GPs and wider, but to get their engagement as to how they want this to run and the best way to engage and what would be okay from them from a time input point of view to be able to direct people into this service. So this is our pathway. So we've got the antenatal and postnatal element, and this is going to be for every single person that is pregnant and up until that 1 year post. So we want everyone to engage, regardless if they've got symptoms or not, because a lot of people don't know what is involved in pelvic health or think they just have to put up with it, or there's nothing that can be done. So we want everyone to be directed through to my pathway. So self-referral, but clinician referral if not. If someone is unable or unwilling to engage with the pathway, then again, that can be picked up by clinician referral in, and then we'll contact them in the standard way. We've developed an antenatal and postnatal risk assessment. So that covers all the nice known risks, and then all the symptoms for bladder, bowel, pelvic pain, prolapse, and sexual function. That will come through, and this is the thing that really helps us with my pathway, is that that's going to be scored. So they'll either be scored into normal risk, in which case they'll get access to all the universal resources, which are a load of mixed media elements. If something changes, they can announce that during the pregnancy or postnatally to redo the symptom and risk questionnaire. If it then triages and triggers higher, then that's when it comes through to, well, all of it comes through to the team, and we have to say, yep, that's right, and agree the pathway. But then if it comes through to higher, then we can give them more specific additional resources or get them through to groups or online sessions or through to an individual appointment. If they need any onward referrals, then we can do it at that point. So we're really hoping for that efficiency of the pathway there to stop people being pinged from one referral and then say, well, you need to go back to physio to avoid those multiple referrals. And as I said earlier, we'll make sure that we're really feeding into the existing pelvic health teams, and there's that two-way process. And that is whistle stop tour from me. So I'm just going to hand over to Jude now.
Hi, everyone. Thank you very much, Helen.
Welcome.
I'm just going to share my screen for a moment. It is coming through, it just takes its time. Something's happening, I can see from this end. Can you see anything on your screen yet?
We can see PowerPoint, it's just not in presentation mode.
Yeah, okay, great. Thank you. That better, David?
Yeah, super.
Okay, good afternoon, everyone. Thanks very much for your time. I'm going to take you through Sheffield Teaching Hospital's deployment of an antenatal self-referral process, which predates some of the perinatal requirements which are around at the moment. But it's just to give you an example of somebody who's already been at this for a while. But just before I do, I wanted to bring your attention, in case you haven't heard of the HTAAF, catchily named the Healthcare Technology Adoption and Acceleration Fund, or it might be Acceleration and Adoption Fund. It's just been announced last week, and there is apparently £30 million that people can access via your ICS in order to use technology to help you deliver the services. I don't know if everybody's heard of it, but if you are interested in that, then we can give you a hand in filling in the documentation. We haven't actually seen the form yet, but as soon as we do, we can share it with other people, or you can go to your ICS. So if you are interested in having a look at that, you can contact my colleague Pete Beaumont, and we can send out his email address after the session today. Okay, so I'm just going to review the antenatal self-referral service that we set up for Sheffield several years ago now, actually. And there, I'll just move David's picture around the screen. Their original objective of setting, so Sheffield Teaching Hospitals were already using My Pathway in their MSK services generally, and they were allowing pregnant persons to self-refer into MSK if they felt they had a problem. And what they were hoping to offer was a single point of access, exactly the same as Helen, increased access to the pelvic health services because they also have limited clinical availability. But they wanted to increase the quality of the resources and the information, the self-help information, and speed up the triage service. And they wanted to standardise the triage service. So prior to having this service, they had an answer phone where pregnant persons would phone up and leave a message on the answer phone and leave very differing degrees of levels of information. So sometimes they leave their first name, not their telephone number, and things like that. And they hoped by standardising and streamlining that would reduce delays in patients actually getting their treatment. Overall, they hope to reduce DNAs because My Pathway has got appointment reminders and things like that built into it. And they wanted to provide self-help resources as early as possible. So that was their original objectives. And this is what their PR, if you like, to the patients looked like. So they put this leaflet in every person's maternity notes to allow people to self-register, and they go to this URL, they put in their NHS number in the first part of their postcode, and then the system recognises who they are. And when they can create their login, and when they create their login, they get this lozenge. I'm not sure if you can, David, can you see my pointer moving around the screen?
I can, yeah.
Okay, great. So the first thing they get in Sheffield is welcome to the Women's Health Physiotherapy team. So it's a welcome message with some information about it. And then they get some support information with self-help resources. And this self-referral questionnaire is actually the triage questionnaire. So it's quite a long questionnaire. And if I remember rightly, Helen, you were able to review Sheffield's in making yours as well. But all of this information is completely bespoke. So whilst Sheffield were really keen and happy to share their information with other people, as I'm sure Helen would be as well, you can set this text up to be whatever you like and to be relevant to your own service. Once the pregnant person has filled in the questionnaire, then everybody who's filled in the questionnaire appears on a work list, and the clinician can work through the work list, reviewing what the responses to the questionnaire have been. And in this case, in Sheffield, they were making a decision to send people for individual physio, group physio, or to have a face-to-face, a one-to-one appointment. So this is just showing, for example, like what date is your baby due, and you put in the day, the month, and the year, so that once the person has filled this in, this appears for the clinician. And then their therapy appointment also shows on their timeline, because we have a feed from the patient administration system, stroke EPR, electronic patient record. And then they go to their appointment, and once they've departed their appointment, that shows on the timeline with post-appointment information. What you're seeing on the right-hand side here is information related to the appointment. So it can be a map, it can be other information about, I don't know, parking or anything you like. That helps the patient attend their appointment. As I said, then they get a post-appointment message, which is linked to their self-management resources. And then they have an FFT, Friends and Family type PREM questionnaire, where they're asking patients about their experience. So it's a very simple pathway, but very effective way of streamlining what they're doing. And I think this is actually my last screen. So it's just to show you some of the data that they've collected, which no doubt Helen will be able to do in the future as well. if I can just bring your attention to this 88%. So this is a recent statistic. So Sheffield have managed to digitise 88% of referrals into this pathway. And by that we mean 88% of the people who are self-referring into antenatal MSK services are doing it via my pathway. And the other 12% are doing it still via paper, because obviously it's not for everybody to use a digital solution. But I think 88% is higher than they were ever hoping for, so it's a really good result. The rest of the statistics refer to the first 6 months, so they had 267 referrals, 4% of which were triaged to telephone, 38 to video, and 58 to one-to-one appointment. And one of their main aims, as you saw in the first place, was to reduce the DNA rate. So their original DNA rate was 10%. Sheffield Teaching Hospitals overall was 7.6%. In the pilot study, they managed to achieve 2.7%, and they have managed to maintain that 2.7% DNA rate over several years. So obviously that is a big improvement and something that they were looking for. That's it from me for slides, David. So shall I go over to the questions I have for Helen?
Yes, please.
Thank you very much, Helen. So if we just start off, Helen, we know that there's a deadline of March 2024 for perinatal services to have single points of access with self-referral capability. How do you think digitising these self-referral pathways at Birmingham will improve the accessibility to women's health physiotherapy?
For us, it's all about that access for all. So we don't just want people who are symptomatic to engage with the service, because we've got that massive preventative focus as part of the project plan, which is also part of the national plan. So really, it's that removing the gatekeepers and getting access for all, so that everyone gets triaged for their individual risk and symptoms as they are now, knowing that they can re-engage with it if things change, and then getting that preventative information out there in multiple formats. And then if they do need to come through for treatment, their quality of wait times improve because they've had access to all the resources whilst waiting for that input.
Okay, thank you. And are there key areas of the service that you're targeting to benefit from this, or?
Across the board, really. But as I said, I think it really comes through to that preventative focus thing. We're shifting it from it being we only see people currently who are symptomatic and they know they have symptoms, to actually breaking that taboo, opening the conversation, and getting that information out there.
Thank you. And where are you expecting to see growth? So one of the benefits that we often hear about from my pathway is things that were previously not visible become visible.
Yeah, that data.
Yes, yeah. So so obviously the reality of the information is out there, but you can't necessarily see it. So where are you expecting to see greater data insight?
All over the shop, really. We've got the national surveys that we will be issuing through my pathway. So we're going to be able to collate that service data for feedback, which we need to report on. So that's going to be amazing that it's all in one place. But also specifically who's engaging. We've got such a diverse population. We'll be able to tell who's engaging with it, to be able to target who we try and get out to engage within the community, because at the minute it's a bit of a needle in the haystack about where you start that engagement, and this is really going to help with us from that point of view.
Okay, thank you. And once you've got that greater data insight, how do you think that's going to help clinical teams to improve the service? Because having the data is kind of this, what's the so what factor? What's going to happen once you get that information?
As I say, to get that community engagement, to be able to target into certain population of seldom heard voices particularly, but then also knowing who's actually, what the makeup of the service, so how many are coming through with X condition, so that we can then tailor how many sessions we offer for antenatal versus postnatal, for pelvic pain versus pelvic floor specific or prolapse elements. So until we get the data, it's a little bit hard to tell, but it's just to be able to see who's coming through the service and what input they're getting and what outcomes they're getting.
Okay, thank you very much. So I'm guessing that most of the people we have on the webinar are people who are interested in the service provision, and they're clinical specialists or people in with responsibility for delivering the service. So from a practical perspective, what IT resources have you required? What's everyone else going to have to ask their IT department for?
Yes. So IT input is king, as well as information governance leads. So get to know your information governance leads for your trust. We've had massive involvement from the informatics leads and the data management development leads, as well as right from the offing, the chief technology officer, to try and get a picture of that, the overall capability of the trust or capacity for the trust to take on a new IT element, but also then the people who will do the nitty gritty, getting the data from Badgernet and getting it to talk to my pathway. So yeah, but especially linking that with then information governance leads. And the Badgernet midwives as well have been integral.
I'm not surprised you raised information governance as well, because obviously when you're working across different organisations, unfortunately, everybody has sort of the same questions that need answering, but they're all subtly different.
Yes.
My next question was going to be what players you need in a project team. So you've obviously already mentioned the Badgernet midwives and IG as well as IT. Is there anyone else that you feel is instrumental in the project team?
We've got Raj, who's our project manager, and she has a fount of all knowledge working across the system, and that is integral to point you in the right direction to the right person. So, and to push things forward, that has been invaluable. We've had access to a wider project working team, so consultants, specialist midwives, MVP reps. So it's been co-produced throughout. So again, that has been an integral element from the off.
Okay, thank you. How are you going to, it's all very well, we've all put this effort in, you've got the pathway available to go. How are you going to tell patients about this, and how are you going to educate them about how to use this, and how you're going to achieve the high level of engagement you're hoping for? Like the benchmark's 88% now.
I know.
The competition
That's what
is
we
on.
need as well. That's what we need. So all the usual suspects. We've been working with Make It Creative, who've have been working with a number of the earlier implementer sites to work on patient literature and posters and that element. We've done a number of resources for social media content as well to get it out there, because people do engage in that way. So we need to be amongst that. We've really linked with our MVP leads and third sector organisations, so that we're getting out into those organisations that are actually in the community to work with them. We've also produced some lived experience videos with service users giving their experience of pelvic health elements and how they've engaged with not our service, because it's not quite there yet, but in terms of pelvic health and how they've engaged before, to try and normalize that conversation. And now we're already very near to go live. We're looking at local influencers and to try and get those engagements, to get the word out there. But I'd still say the biggest element is making sure, I said earlier that we'd been doing pelvic health training across the 18 months-ish that we've been building up to this. And it's clinicians, we need the health visitors, the midwives, to be asking those questions at every contact. And when we've sounded them out about how that would work in their time pressured environments, they say we can happily ask the question, but we need resources and somewhere to direct them to. And that's exactly what this gives us. So they've been invaluable throughout. So I've got all of their emails. I've been bombarding them with, this is now live. Tell everyone about it, get them engaged. And again, if clinician has to refer in, then it's a simple few steps to follow. It's not going to be, they've got to fill out a 2-page referral process. It's a few details, and then it's on to the individual to complete. And if they can't, then that comes through to us to assist with them.
Thank you. The purpose of today is to share your experience with other people, and kind of what's difficult is nearly more important than what goes well, because obviously those are the things that people need to be prepared for. What did you learn from talking to other NHS organisations?
About the process? Yeah,
or just getting to this solution.
It takes time. It really does, and we're bringing together trusts to work together and create that equity of care. And so it's learning how those individual trusts work and bringing it together and getting that agreement between them. So that does take time, but it's getting to the right people and asking the questions about how that big picture fits, so there's no surprises, because we have had a few surprises along the way, and seeing if there's any leeway on whose version of documents you complete, or whether it is that you've got to complete the separate ones. But again, you need to know, because it takes that time element on it.
Yeah, thank you. And well, I was just going to ask you what advice you would give to other people currently planning to digitise their service. Is there anything else that you haven't already touched on?
I think comes back to finding those right people, information governance and the infographics and the chief technology officers, so that you're aware of where your trust sits in their overall capacity and approach to digitising things, and knowing what all the I was going to say hoops you have to jump through, processes that you have to go through to get it where it needs to be, and then link it with the ICB as well, or ICS, because they're integral to this element as well. So we've gone through the system, for example, with the IG and IT at both trusts, and we're on the final stages with the ICSs now to then link it with the GP systems. But again, that's a separate entity, even though all the work's been done at trust level as well.
Thank you. And I can see that we've had quite a lot of questions in, so I'm going to make this my last one and stop hogging it. So what outcomes or impacts are you most looking forward to seeing realised over the next few months?
I think it's about getting that empowerment to women and birthing people, that they can self-refer and engage and get that preventative information. And then, as I say, those ones that then need to come through to us have had that improved quality of weight. Once it's live in English, we are looking at all the translated versions as well. So really hoping that opens up that engagement element.
Yeah, there has been a question about languages actually, so we'll probably go into that when David raises that.
Yeah.
And just a final point from me. We've just completed a programme in Wales, which was a trial of what they call ESOS, EC on symptoms. It's very similar to PIFU, and from our perspective, it's very similar to self-referral.
Yeah.
And they got the most amazing feedback from patients about their resources. So you could see, so this example is orthopedics, but people were saying, I didn't realize I could exercise because I have an injury and I thought I shouldn't be exercising. Or I didn't realize by making these few simple changes that I could improve my sleep pattern. And they got a very, very, very rich response, because patients can, in this case, pregnant persons or birthing people can review the resources and give it a 1 to 5 star rating and leave textual feedback on how they find the resources.
That's going to be invaluable. Yeah,
what struck me about that in the Wales example was that's information that's probably very difficult to get at the moment, people's opinions and so forth. So okay, I'm going to stop and throw it out to the audience. David, do you want to orchestrate?
Yeah,
Thank
of course.
you.
So first question is, how do you avoid digital exclusion? Is my pathway available in other languages?
So there are a few elements that we're working on locally. So from the outset, it was agreed that it needed to be available in multiple language to not feed into the known equity issues. But the process we work with My Pathway, it needs to be up and running in English first, because then we need to make sure it is working as a process and we don't want to make any changes. And then once we're happy with that, we've put funding aside to translate into 10 of the most common local languages. So we'll take a language at a time and work through that. So yes, we've also been working closely with the maternity link support workers that we have working across Birmingham and Solihull. So they support women and birthing people who English isn't first language, and or have other social elements that they need input with. So particularly with the different languages, we've been working with them and saying, right, this is what we're proposing, and asking them what the engagement would be like, and it has been really receptive that there was this available, that they can facilitate those who don't read their spoken language. But yes, we have that all in the pipework.
Super.
Okay.
How does my pathway interact with other NHS systems such as EMIS and Rio?
Shall I take that one, or Simon? I think I've just seen Simon Bramwell pop up on the call. Simon, do you want to answer that? You're on mute, Simon. Of course.
Can you hear me? Yeah.
Yes, we can.
Yeah. So, well, we take a feed from the PAS. So the main method is that we take data on appointments and information that would help us to trigger the necessary pathway information direct from your own internal IT systems, and we work with your IT departments to facilitate that. But typically the best method is HL7 feed, but we can also take data dump in any CSV type format. In the case of Birmingham, we have an extract that's coming in for us that gives us the appointment details and also the birthing status of the mothers, so that we know whether there's been a stillbirth or a live birth or what's happened in the past, so that we can trigger the necessary pathway information accordingly. So yeah, we work with your IT department basically.
Thank you, Simon.
Okay, the next one is for Helen. Do you know what percentage are engaging with self-referring in, i.e. do you manage to screen everyone?
It's not live yet. So when we go live, which is hopefully in a week or so, then we will know exactly how many are engaging with. We'll know how many are then accessing self-help, who then needs to come through to more input as well. So the aim is that as many people, and the midwives were going to be, and the health visitors are going to be integral with this at every point contact, just nudging people towards my pathway. Have I answered that question?
I think the Sheffield answer to that is 88%.
Yeah.
And your answer is TBC.
Yeah. Also locally, so work with your equity lead as well, because our equity lead, they're looking at digital lending libraries and things like that, as well as we've got, as I said earlier, the maternity link support workers who are supporting people whose English isn't the first language, or so yeah, find out what you've got locally.
Super. And this is a follow-on from the previous question. Does my pathway link into existing maternity digital systems?
Simon, do you want to comment?
Yeah, pretty much the same as I said before. I mean, it depends on what your system is, but when you say link in, I mean the two-way process. So basically, the information that we get from your existing system, for in this case Badgernet, in Birmingham's case, yeah, we take information as required to tell us what we need to know to trigger the behaviour of the system. In terms of getting information back, that's something, again, depends on your local requirements. And we're working on data warehouse feedback so that questionnaire data comes back to you in whatever form you need. But obviously the information is already available in our portals as well, so that you can access it there. So it depends what you need. And obviously every trust is different. Every trust uses a different system. So we have to integrate on a case-by-case basis.
Yeah, we've never failed to integrate where people wanted to.
Super. Thanks, Simon. Next question. Who does the triage in once data is added to the app? Is it automatic or clinician-led?
Shall I take this as what we're doing? Or
yes, please.
So with the risk and symptom questionnaire that we've developed, we couldn't give it a score, a number, because we were like, well, they only have one concern, but it's really troublesome, versus multiple little things. So that didn't work. So then we've green amber read it basically and decided what happens to that. That then all happens in the background through my pathway, but then it comes through to working lists. And Simon, correct me if I'm wrong here. But then we will see, and we've got to agree that yes, that's a green, and then say yes, that sets off this pathway to get access to all these resources. And then the ambers and reds we can click into, because all the information is going to be there, and decide onward action. So whether that's some condition specific resources or access to specific other groups or things, or whether it's saying yes, you need a one-to-one appointment and get that booked. So we obviously don't know the exact time element of that at the minute, but the greens are going to be as quick as clicking a button to confirm, and the others, because the information is all there, is going to be very quick to then decide that onward action. And it has to be this way because it's not, Simon, what is it not? It's not
a medical device.
There we go.
Medical device.
Yeah. There we go.
Yeah, so My Pathway cannot make a clinical decision for you because it's not a medical device. It's not an AI type solution. What we can do is present the information to you in such a way that you can most efficiently confirm that that is the action that you want to take. So the decision is a clinical decision in the end. But the time element to it is really reading through the responses that you've asked for. That's going to take the most time. And once you've done that as clinicians, you know what to do. And then it's just a click of a button.
I think the key thing is that if any question in the questionnaire scores as a red, in other words, it's a serious issue, then the whole questionnaire gets marked as red and it will be drawn to the attention of the clinicians. If it's only if the highest concern is an amber, then the whole questionnaire becomes an amber. And if none of them are amber or red, then the questionnaire is scored as green, and then you'll be able to see that in one click. You'll be able to see that questionnaire is green. You know, you can look at it, but you don't have to give it top concern.
Brilliant. Does it provide easy evidence for assurance of meeting the national requirement?
The national requirements for the Perinatal Pelvic Health Service, if that's the meaning of that, then yes, because it's single point of access self-referral. Everyone is screened from a risk and symptom questionnaire point of view. We will be issuing the National Maternity Survey and the Perinatal Pelvic Health, which is the physio element of it, through that, and then being able to bring all those results together then to feed into the national KPI requirement that we need. So yes.
Brilliant.
I think, Helen, you provided us with your reporting requirements right at the beginning.
Yes, we did.
Yeah. And we reviewed those and said, right, these are the things that you can easily get from My Pathway, etc. And this is how it presents itself. So
and we built in
Helen
lots
said
of different
we can
KPIs.
Do it on a case-by-case basis. Yeah.
Not KPIs. We've implemented a lot of patient-reported outcome measures onto it as well. So we're going to have that that data, the validated data there as well.
Wonderful. Which risk assessment tool have you used?
So we had to create our own because there isn't one at the minute. The Birmingham are developing the Perinatal Pelvic Health Self-Assessment Tool, but we don't know exactly what that looks like as yet. And they are getting centres to trial that with people at the minute. So we developed the risks are all against, we've kept it specific to the known NICE risks and stuck to those rigidly. And the symptoms, we have pulled together from various patient-reported outcome measures for against those 5 areas of pelvic health, worked with service users and other clinicians to make sure it's as user-friendly as possible and gets the information we need to make that decision. But there isn't a validated one out there that does it all at the minute.
Okay.
That took a lot of work.
I bet. Can My Pathway be adapted for symptomatic patients rather than self-referral?
Well, the self-referral will pick up those who are symptomatic or not. It's just we didn't want it to be a service that only comes through to those who are symptomatic, because some people don't know they are for a start, and this is a preventative focus. So it will pick up everyone across the 5 elements of pelvic health. So bladder, bowel, prolapse, pelvic pain and sexual function.
Okay. Who is in charge of keeping resources up to date?
Me.
And how will that be kept going?
Yeah, that will be us as the service. And the good thing about My Pathway, and we discussed this at the outset, so we will have ability to amend and update things locally onto My Pathway, so we don't have to keep going back to the My Pathway team and say, we need to amend this resource. So obviously there are limits. If you're redeveloping the pathway, then that's a different element. But if you're just saying there's a new resource I want to upload, then we will be able to do that. Simon, am I right?
Yeah, so there's 2 ways of handling resources. One is that if you host the resource yourself, for example, on a web page or a locally hosted PDF file or something like that, then you're in charge and you can update, you can keep it up to date. And when a patient later on goes and loses the same resource again, they'll get the updated version. If you want us to host it in My Pathway, then you have to inform us when you want to make changes, and we will change it for you. But it's basically, it's a process of collaboration, and it's how you want to manage it, really.
Yeah, we would encourage you to host it yourself, because then it's under your control and you've got the version control.
Yep.
Brilliant. It was just with an eye on time, it'd be the last few questions now. Will there be any other webinars or meetings coming up with the My Pathway team to provide more detailed guidance on recommendations for fitting it into trusts?
I certainly think there can be, if people are interested. So we did a couple of these antenatal webinars a couple of years ago, and obviously we put this one out, and it's been very popular, which is fantastic. So if you would like to feedback what else you would like to see or what you'd like to hear more about, then we can definitely put on another webinar, or we're happy to have a chat with you directly, with you and your teams, to find out what your requirements and your individual questions are. And we can organise that through my colleague Pete.
Wonderful. Is this digitisation process best managed at ICB level or individual trusts within an ICB? And how easy is it to get all trusts within an ICB doing the same thing?
Our trusts all worked with Badgernet, which is a massive help because that's where we're pulling our data from. You kind of need all of those elements, because the funding in that NHS England will put forward will go to your ICSs. So you need to start conversations with them about how that's going to be then pulled to the trusts. But equally, we tackled it from trusts first. However, ICB or ICS were aware of it at that point, because we have a combined meeting where they attend at digital level and operational level. So it's kind of all together, but the trusts absolutely need to have the capacity and get IT and informatics on board. Otherwise, no matter what ICS say, it will prove challenging.
Okay. For the questions that we run out of time on, we'll do a follow-up separately over email, so don't worry, all questions will be answered. Will pre-existing patients use My Pathway, or will it just be new patients?
No, as soon as we go live, it'll be harder for those who are postnatal and discharge, but that's where the wider community engagement comes in if they're not with the health professional. However, GP is going to be linked with GP systems, and all GPs are aware. So if someone goes to GP with an element, then they can engage. So up until that 1 year post birth, yeah, we want everyone.
Okay, thank you. And thank you so much for your time, Helen.
You're welcome.
It's been a very informative and insightful webinar, and thank you, Jude, as well, and Simon for joining us as well.